like to start then?
I can go anytime if you want me to.
Okay.
Okay, I can show a few cases, start off with. Let's see. This one is quite a nice example of a penetrating atherosclerotic ulcer. Of course, it's not going to be visible on the chest radiograph, so let's bring up this. And let me just bring this alongside to remind myself about the history that you can see there. So scroll down to here. We see there's a lot of atheroma in the aorta, but I think this is certainly quite consistent with a penetrating atherosclerotic ulcer in that location. It's focal. It's quite large. There's the connection with the lumen. It does go into the wall. Lower down, I'm not entirely sure how much of what we see here adjacent to the opacified lumen is intraluminal thrombus versus maybe some intraluminal hematoma. I'm not really sure. It's not really centered directly about that. So I'm not sure about that, but I think this is quite consistent with a penetrating atherosclerotic ulcer. You can see she's an older person. They just controlled her blood pressure, and she's asymptomatic, and they discharged her with that. So anyone concerned that this maybe isn't that and it shouldn't be in my teaching file as a PAH, PAU?
Well, so below that, don't you think that's hemorrhage? Below that,
Yeah.
like
In the wall?
yeah.
Yeah, that's what I was thinking. I wasn't sure how much was in the wall and how much was intraluminal thrombus, but
So
certainly
did they
that.
discharge her like it was a type B dissection, or did
Yeah,
they?
just by virtue of the fact that she became asymptomatic and her blood pressure was controlled. She's 86 years of age,
Yeah.
and they decided just to treat her medically in that fashion.
Howard, how far down does that hematoma go?
Let's have a look. I'll scroll down from up here, go down a ways, fair amount down to about there somewhere. Then we have the hernia.
So, Seth, is your point that if it's elongated hematoma like that, it implies dissection rather than penetrating ulcer, which would stay more localized in terms of?
Yeah, I mean, this is an interesting question. I'm actually going to invoke all of you because I put together 40 or 30 cases like this and not like this that I need readers to do studies from different institutions of cases just like this of what do you call things like this. I would call this like to me it's a focal intimal disruption and a thrombosed. There's hemorrhage throughout the. There's an intimal disruption and there's hemorrhage throughout the. Throughout the media. To me, it's like a type. Yeah, I think it's basically like a dissection that only has one entry point and doesn't have an exit point to make the second luminal connection. I mean, again, the treatments vary. I know at our institution they would have stented her, but I think there's some heterogeneity out there in what people how people read these things. Yeah. I know at our own institution, we discuss these things in depth and can't come to a consensus about them.
Yeah. Yeah, I'm not really sure. I will agree that there are some intimal calcifications, for example, here. But I was wondering how much is just intraluminal thrombus in an atherosclerotic aorta versus actual intramural hematoma. But your point's well taken, Ivor.
I mean, I don't know what other people think. I know a lot of people are on silent, but
yeah,
I agree. I think that there's no consensus. I mean, who knows if this is a PAU that led to a small intramural hematoma. I hate when we see these chronically where you just see a focal outpouch and it looks like it's probably an old PAU, but people call it a focal dissection. I don't know.
So just out of curiosity, are you guys interested in? I do have 25 or 30 cases ready to go as anonymized to basically just get a one sentence diagnosis of what you would call something to show that there's some things we agree on completely, and other things we just are all over the board with.
Yeah.
But I'll email you guys the details.
Okay. All right. Okay, this next case is a very nice example of what turns out to be pulmonary hemorrhage. The CT findings and the chest radiographic findings are very consistent with that. Here is one episode from June of 2015 with these multifocal, mostly ground glass attenuating opacities in the lungs. Chest radiograph will look like that. Even just prior to that, she carried a diagnosis of antiphospholipid antibody syndrome. So that was diagnosed apparently in the context of a pregnancy by obstetrics, as you can see there. And she has had another episode of it more recently in November of last year. She's been treated with steroids and some other immunosuppressives with only partial success. So she's a bit of a management dilemma, but suffice it to say that certainly one known cause of pulmonary hemorrhage, relatively uncommon compared to the other ones we see, is the primary antiphospholipid antibody syndrome, or even secondary antiphospholipid antibody syndrome. That's a well-known association, and just a nice example of that in this patient.
Does she have lupus?
She does not. No. This is just a nice example of seeing something in a particular location and wondering what it might be. So here we have a chest radiograph. Yes, there's some pleural space disease, but I'm really showing it for this object, which is down here. So on this particular frontal projection, it projects down here, and on the lateral projection, it projects here, anteriorly and inferiorly in relation to the heart. And this turns out to be a Amplatzer plug that was put in for a post-MI VSD. The patient came here with that diagnosis, and at some point that was treated in that fashion. So an Amplatzer plug or a VSD. Just a nice explanation for why it's located where it is in relation to the left ventricle there. Okay. Let me show you this one. And this is a patient that has, as I'll indicate in a moment, a inflammatory myopathy as well as skin lesions. So let me just bring up alongside the clinical information. She presented with very definitely a myopathy, and there was a question whether she had some skin changes. In the medical record, some people said yes, some no, but someone put question in mechanics' hands. But as you can see there, she is positive for an antisynthetase enzyme. So this is the antisynthetase syndrome with myopathy and maybe skin changes. And certainly from the point of view of the chest, the findings that we see here in the lung bases, which are very florid down here, let me bring up the axials, are very consistent with what one might see in that syndrome. So these opacities that we see down there, these subpleural, fairly extensive, patchy, ground glass and consolidative opacities are very consistent with the cellular interstitial pneumonitis, presumably maybe some organizing pneumonia or combinations thereof, all of which may occur with the antisynthetase syndrome. So of course we don't have a biopsy for this, but putting the whole case together and a clinical presentation, this is very consistent with what one might see with that syndrome. So a nice example of that. The CK was up, and those are the antibodies that she has. Okay, let me show one more, then I'll stop. This one is just an example of a thing that was described recently in the JTI. So these guys reported something that I've seen a lot. I'm sure you've all seen it a lot as well, but they gave it a name. So the observation is that on CT, particularly thin section CT, you will sometimes see small opacities adjacent to an airway, When you see it on FOSS, it looks like a little nodule, but it's adjacent to an airway. When you see it here in their example, alongside the length, it looks like a double-barreled thing. So they've called this the double artery sign, in which there's pathology in a bronchus adjacent to a vessel. And I've seen this many times on CT in oncology patients, and have described it as airway stuff or inspissated mucus simulating a nodule. I always teach that, don't get fooled by that. So that's a nice example of that. And here's a nice example. I've got many examples that I've kept, but here's a nice example. So this is MIPS, of course, and if you do MIPS, you'll see this quite often. So let me just try and pick out a place where you can see that phenomenon. Let me try and pick out a nice example of it somewhere that I had. Let's see. There was a place somewhere here that I had a nice example. It's places like this where you see a little opacity adjacent to a vessel. Sorry, let me just scroll down. There was one area, like here, for example, and okay, right here. So here's a nice example. This one's nice because in this bronchus there happens to be several of them. So we have here opacity, nothing, opacity, nothing. So there's a bronchus right there with stuff in its lumen. So that's kind of a double artery sign. This one is kind of an interrupted double artery sign, but you get the idea. And then, you know, if you have a look at thin cuts, that doesn't seem to work for me. Trying to bring that up. When these are very small, you can see how you can potentially get fooled by them. So here they are. Here's a kind of 3 of them in a row. But I'm sure you've all seen that before. But this is the first time that I've seen someone just give it a name, double artery sign. And I guess that's reasonable.
Or just mucus plugging.
Or just, presumably it's mucus, although I've seen it stay. So sometimes you think if it's mucus, I'll cough it up. Next time you image the patient 2 or 3 months later, it should be gone. Sometimes it is, sometimes it isn't, sometimes it just stays there. So I don't quite know what that is. So usually Leif and I just call that inspissated mucus, but I don't know what else to call it. But these guys have obviously seen it before, and they just gave it that name, double artery sign. All right, I'll stop there for the moment.
Okay.
Jeff?
Yeah, thanks, Howard. All right, who would like to go now?
I got cases.
All right, Seth.
All right, can you see the beautiful aortogram?
We do.
Yep.
Okay, so this is a young kid, 23, 24, at the gym doing deadlifts, and all of a sudden had extreme abdominal pain. Went, I don't know, but wound up at the hospital, basically cold extremities, cold lower legs, as you would expect, and also with supposedly some mild cognitive issues. So they got I have to apologize for the quality of the study. It's not our study, it's an outside study. It was kind of a neck, but they went all the way down, and it's a really bad study, but nonetheless, you could see this large lesion in the left atrium, predominantly hypoattenuating. There is, and does appear to be, this connection. Got it. So this is so awful. I'm embarrassed to show it, even though it's not ours. There appears to be this connection to fossavalis, which was confirmed on surgery. You can even see the little fronds on this guy. So this was one of these villus myxomas that these guys have the tendency to embolize, and it shot off a big one, and it shot off and lodged in his aorta. Here's the images from the surgery where they pulled it out. That's from the heart, not from the aorta. But it's just this gelatinous goop. It's just so characteristic of these kind of villus-looking myxomas, and these little fatty globules, mucousy things, just break off and embolize. And I've shown a bunch of cases here, lodging in the brain, lodging elsewhere, and I've seen them lodge in the legs, but this is the first one I've seen present with a full aortic occlusion. So Pretty impressive, even though the imaging is unfortunately suboptimal. And there would be a differential if, I don't even know. There is a differential because the imaging is bad here and you can't tell this, but it's most likely a myxoma. I found that sarcomas, left atrial sarcomas, in my experience, even though I haven't seen as many, tend not to be as friable and tend not to embolize like the myxomas. And talking about sarcomas, here is a young woman who had a known history of an atrial sarcoma and had it resected, and for some reason she was clear for a while. She got lost to follow-up, and you can see there's this large, even though it's hypoattenuating, it has increased. It measures about 60 Hounsfield units. The interesting thing is you can see the thickening of the atrial wall, and additionally there's thickening of the annulus and along the posterior leaflet of the mitral valve. So I'm concerned that those were invaded as well. So this person is going to undergo here, and I can show it on the. These are delays and some other imaging, and even though it looks like it's enhancing more on delays, if you do a map out a curve, like most kind of more aggressive malignancies, it's much more avidly enhancing in the arterial phase than it is in the portal venous and delayed phase. So here's the portal venous phase, and again, there's just a regular thickening here of the mitral valve. So what they're going to have to do with her, because it extends around here and goes by the ostium for the pulmonary vein, is they're going to do an auto atriectomy and then reinsertion. So what they do is they take out the heart, literally just take it out, put it into an ice bath, cut out the atrium and the valve, and just open that up on a table and scoop away all the tumor as much as they can, and then re-anastomose the atria, and then put the heart back in. So, it's a surgery that we've done here a couple times. They do it. There's a guy in Texas that's, I guess, well known for doing it. But so that's what she's going to have. She's actually going to have that tomorrow. And we presume she has a history of a spindle cell sarcoma of the left atrium, and that looked very similar, and we are assuming that it's a recurrence. It's definitely a malignancy. So, not attached to the fossa ovalis, and we'll see how she does without. I was like, how do you keep the heart alive for 12 hours? And they just said, put it in an ice bucket. So, I guess that works.
It sounds like Texas, doesn't it?
Yeah, no, they got, it's just like, yeah, no, they just put in a bucket of ice, and then you put in some freezing gel solution, and it's fine. I said, for 12 hours? They're like, yeah, you can keep it there for a day or two. And I'm like, that's somewhat odd. And then the last cardiac case, this is just writing a radiographics paper on this thing, and on this stuff, and this is just a nice example. It's not that, you don't see them, you see them, but to have a nice gated study of it is relatively uncommon, at least in our experience. We see them not that infrequently, but often it's non-contrast. So this is a person many years after bypass. Usually it happens like 13 years after bypass. I think this patient was like 15 years after bypass. And you can see the saphenous OM graft. And it's clearly got it's aneurysmal to start, and then it has this very large aneurysm. And it still fills, and kind of got clotted off distally. But this is just a nice saphenous venous graft aneurysm. Again, most of the time we see them on non-con CTs, and we suggest a study, and they just said, we're not going to do anything about it. But these actually do have a somewhat nasty. They should be taken care of. They can rupture, and they can grow quite rapidly and lead. We have some that I've shown maybe in the past that are absolutely massive. We have one that's like 12 centimeters, and basically send the guy into tamponade because it was compressing his whole heart. So usually they coil embolize these things now, but just a nice example of a saphenous venous graft aneurysm. And those are my cases.
All right, thanks, Seth.
Jeff, I have 2 QQs.
All right, let's pull yours up.
Are we all seeing a nice röntgenogram here with patchy lung consolidation?
Yep.
We see it.
Okay, so there's patchy lung consolidation, and this person had a CT around this time. And you can see that there are all of these well-defined lung nodules here. Some of them have little air bronchiolograms in the center. So we've got a lot of nodules in this young woman. She has probably some pulmonary hypertension here. Her pulmonary artery is a bit dilated compared to her aorta. And she didn't always take and see that there's this mostly ground glass with some denser lesions sort of hugging the hilum here. You know, I start to think of Kaposi sarcoma for this sort of thing. There's accompanying pleural effusion. This person had skin lesions that were biopsied. Things cleared up, and then there was a change in medication and things got worse. Now we have all of this consolidation that's cleaving to the apices. And let me show you CT around this time. You see that there's this widespread lung consolidation here with accompanying pleural effusion. Trying to make it peripheral here, but it's not really cooperating very well. Spares the bases relatively. And this is Churg-Strauss, which now has a different name. It's EGPA, the current nomenclature. And this was confirmed with an eosinophilic, they biopsied the skin lesions, they found an eosinophilic vasculitis with necrosis. So we have evidence of tissue eosinophilia. The person had, I think, a peripheral blood eosinophilia as well. And I don't know whether they recovered eosinophils from the lung, but this is biopsy-proved Churg-Strauss here with widespread lung consolidation. So what do you think? Hemorrhage or eosinophilic pneumonia is the cause of this lung stuff? It should be eosinophilic pneumonia.
Looks like eosinophilic pneumonia.
Yeah. So this is the wildest case I've seen too, with this, especially on this flare here with this dramatic upper lung consolidation. And I don't recall whether I've seen pleural effusion in this setting before.
So David, they can get cardiac involvement, so that potentially would be a cause of pleural effusion.
That's right. And this person did not have known cardiac involvement. That was not one of the sites. It was skin and lung were the documented sites. And also, I think there was not a sinusitis, which is common in this. The other thing they get is peripheral neuropathy. He didn't have that, but the skin lesion biopsy was definitive.
So they did a cardiac MRI, because usually it's a myocarditis in these guys. Do they do that, or they just said cardiac's fine?
He didn't have cardiac symptoms that warranted it. I don't think that he had a cardiac MRI. Okay, those are 2 cases.
All right. Okay, I can show a few here. So I'll start with this one. Let's show another röntgengram here. You see a frontal radiograph. So this is a guy who's got a history of pancreatitis and has some belly and chest pain, and you can see he's got pleural effusions and the abnormal mediastinal contour here. There's thickening of the paratracheal stripe. There's too much density here in the lateral area. And then if we go to the lateral, you can see just the big effusions, and not hard to see back in here, but I think his CT is quite impressive. So you'll see there's already this abnormal fluid collection in the lower neck. As I scroll down, you can track and see all of this in the mediastinum, aberrant subclavian, and it's just encasing the trachea, the esophagus. Just works its way all the way down the mediastinum. So this is the largest pseudocyst I've ever seen. Going all the way down into the abdomen. You can see some other pockets of it. But this was actually sampled and was a pancreatic pseudocyst. I don't know, have you ever seen one all over in the neck?
Yeah, this is the most extensive one I've seen, I think, too. How extensive that fluid accumulation is, all the way up and down. That's pretty impressive, yeah. I know Travis once showed us one that may be about the same, but yeah, that's impressive.
I don't think mine made it up into the neck. I think this one wins.
Yep, that's a lot of fluid. Wow.
Yeah, it's a lot. That's an old case one of my residents showed me too. It's a few years ago. All right, I think you guys are going to really like this case. This is an interesting case. So this, I'm going to show you the original, the first CT from February of last year. And this is a guy in his 50s who you won't have too much trouble. Hold on, you probably may not even see it. You don't even see it.
Not yet.
There we go. There we go. This is a guy in his 50s, and I don't really probably need to tell you the diagnosis. It's pretty classic. He's a smoker. So beautiful case of LCH.
Yeah.
I mean, this is about as pretty as it gets. What's interesting with him is I've got a follow-up scan that was about 6 weeks later. And what's striking, and then I'll show you a later one, is the progression of some of these lesions. Let me see. Let's see, 2D viewer. What's the setting again to get them to unlink?
Try Command G.
All right.
To unlink the scrolling or the... We only see one window at the moment, one panel.
Oh, that's right. Let's see if I can... Huh. That's right. There's an issue with GoToMeeting on how to do that. Okay. Do you... Let's see. Well, I'll just have to show one at a time then. All right. Well, he continues to smoke, and they did a CT. This was an outside study, so I'm not sure why they CT'd him again hold on, here we go. Why they CT'd him again 6 weeks later, but they did. And what you'll see is when you put it on side by side, some of these, this thing, for example, was solid on the previous one. It's progressing, and you're seeing more cysts and fewer nodules. But what's really cool is the CT from just this a year later. So the guy, he's cut back, but he continues to smoke. And you'll see that the nodules have significantly decreased, but there's a lot more cysts.
Yep.
Distribution. But he actually presented at this time, and this is a biopsy case. They biopsied the outside hospital under a needle, and this is LCH, as you would expect. But he presented with chest pain, and that's what prompted this CT. And he actually has developed, if I can find it, there it is, right down here, a soft tissue nodule and a fracture of this rib. And he also has another bone lesion, if I can find it, right here. Little cortical defect of this vertebral body. A little punched out, no periosteal reaction. It's not the disc. And if I put it up on I think a sagittal, we'll see that. Yeah, right there. You can see. It's a little punch.
Oh my goodness.
So this is, this is LCH that's progressed somewhat. But, natural history of it. He's cut back, but he hasn't stopped all the way. So it's a progressive LCH. But, the literature says extrapulmonary involvement in adults occurs in 15%. I think that's too high, but that's because we see a lot more early LCH because we image them and we see them when they're not even symptomatic. But yeah, this is only the second time I've seen bone involvement in an adult. And the last one was a kid, like a young adult, so it was more likely he had the juvenile form. So, with progression, they'll sometimes put them on some cytotoxic agents to try to stop this.
Did they biopsy the rib lesion? Do we know that it's eosinophiligranuloma and not something else?
We don't, and I did raise the possibility, well, it could be a MED or myeloma, but it's really, it kind of makes sense because he's got nothing else going on anywhere, and his lung disease is progressing and becoming more cystic. But yeah,
so Jeff, is it still thought to be smoking related then when it gets outside, gets away from the lungs? Is that still the idea?
The thought is it is, because there are a number of people who have smoking related PLCH who don't get better with smoking cessation. And so probably, there's this whole sort of monoclonal versus polyclonal type. So it may be that it's more monoclonal. But I don't know. I don't know how the biopsy was read somewhere else, if they just called it PLCH, if they did any clonality. Okay, but if you put them up side by side, if you can on your screen, you'll see them. So this is the guy from last week I showed with the crazy pulmonary aneurysm. Hold on, I'll share the screen. So remember, he had the big pulmonary aneurysms and
Yes.
the in situ thrombus. And so we raised the question of a vasculitis, of a Hughes Stoven, and then Hughes Travis commented about, or one of you guys, or maybe all of you, suggested, raised the possibility of, well, could there be an ASD? Because there is all this dense contrast. We knew there was a PFO, and there is intimal calcification as well, not just thrombus. And so they'd done both TEE and TTE, which showed no ASD. And we did a cardiac, but I looked at this with our pulmonologist again and talked about this possibility. So we actually did a cardiac MR, and I got to find the right sequences to show it if I can. Bummer, I think it was 2D flow. No, it's the flow one. I'm gonna have to. I put the whole stack. I put the whole cardiac MR in here, but in just to save time, indeed there actually is an ASD. Oh, it's on the pulmonary MRA. That's where it is. There is an ASD. It's very posterior, and it's the QPQS was only 1.3. We knew he had a shunt, and he does have some Eisenmenger physiology. And what they were telling me about the they did it during some of the study during expiration and not inspiration, so there is some of it, but on some of the sequences you can sort of see it, but I'm not going to be able to find it in a reasonable amount of time. But the diagnosis was an ASD.
I think it's just a reminder that people trust echo like it's the gold standard, but you know, I've shown other cases just like that. And there was a nice radiographics article that just came out with the limitations of echo, kind of reviews echo in relation to CT and MR.
You know, particular, I would say with pericardial effusion, the echo people say all the time that there's no pericardial effusion, and CT shows there are big pericardial effusions.
Yeah,
so
echo's about as good as a portable radiograph. No, it really is. It's shocking.
Right. Well, I think clinicians seem to trust it more just because they don't go and review every echo, but they come down to the reading room or they look at the CT on their own, where they can see the findings. So.
Yeah. Okay. Well, here's another interesting case that I also struggled with. So this is a guy who was referred here for this thing. I don't know what they called it at the time, but you can see there's this collection of contrast. And this is the outside CT, and you can see it's mostly on the levo side, but we have some contrast. He's had a bypass, and you can see this aortic coronary graft that goes to the distal, I think it goes to the PDA, distal right coronary. So there's the graft, and you can see there's the native coronary here, and it looks like it's probably thrombosed. But he has this collection, and the native coronary runs right by it. But what I struggled with it is, it looked like to me that this native coronary was thrombosed, and I was concerned. And then the graft is far away from this, so I was wondering if this was some sort of RV pseudoaneurysm, because it looks like there may be a connection here. Wasn't 100% sure, but I thought that's probably what was going on. It didn't occur to me he would have what actually this turned out to be. And the best sequence is probably the perfusion sequence. And let's see if I can find it in here. I don't know why Osirix always loads the series in different order. So here you can see the perfusion, and think we're not quite at the right slice. We have to get a little bit closer. But right there, you'll see it filling right there. So let's go back. So you'll see, so the right heart fills on this image. RV, so the pulmonary artery is filling. Notice we don't see anything in the RV that looks like a pseudoaneurysm. Now we're starting to see contrast coming into the LV. And then you'll notice right here, this starts to fill in. So it's filling on the systemic arterial side. So this is actually was a pseudoaneurysm of the native coronary artery. And it turns out this guy had staph bacteremia. So we don't know if this was a pseudoaneurysm or a true aneurysm, but I just found the CT really challenging because of the close proximity. It wasn't gated, and I thought about it for a little bit, but then I decided, well, gee, this looks like a thrombosed artery. I don't think there's any contrast getting in there. And I guess the only other clue is the density of contrast here is a little bit higher than it is in the rest of the right ventricle. Although you could argue there's more intense contrast in the apex. I don't know what you guys would have done with this on a CT alone.
So Jeff, is this anywhere near one of the vein bypasses, or is this independent of?
Here's the graft over here. You can see there's the graft coming down. Here's the native coronary, and there's the pseudoaneurysm. It passes.
Does this thing connect with the graft?
No, it connects with the native vessel. See, here's the native right coronary. The graft.
Do you think that they might have nicked the coronary or something when they placed the graft or something? Could this be from the surgery?
I suspect it could be. The graft plugs in down here. It's
way down there.
Possibility, but I guess I was struggling because it looks like the native vessel thrombosed. I mean,
but it's probably retrograde filling from the graft, right? So if the graft's going to fill distally, it's going to go both ways. So it's probably blood coming from the graft going back up towards the pseudoaneurysm, then blood going anterior grade from the RCA ostium distally.
You see, there's the
or it's coming via collaterals.
Yeah, it just doesn't look like there was much contrast in this vessel on either end of it, but it abuts it, so I guess it's in the right place. So that's an interesting one. I've not seen something like that before. Okay, this is a quick one, but a fun one. This thing's been here for a long time, but we actually got a CT of it for totally different reasons. So this is a guy who had a pacer many years ago, and you can see the retained lead, but notice it doesn't go up to SVC. It goes up here, and it goes out to the pulmonary arteries. So you can see on the CT, this isn't retained but embolized pacer wire. So there's where it anchors in, and instead of going up, it forms a saddle embolus of the main PA. But I went back. This thing's been there for over a decade, so nobody's going to do anything about it. But just yet another foreign body in a different place. And this last case, one of our abdominal fellows was working at a different hospital and brought this to me. So this patient presents, let me show you the image, young guy, presents with scrotal swelling. And so this is a scrotal ultrasound, and you can see there's the testis, there's fluid, and then this is the epididymis. And you can see it's really angry looking. It's enlarged, and there could be, let's see, image. This way. So there it is. It's that's just showing some vascularity. Now here's the other side, and this is the other epididymis. So he's got massive epididymitis, but it gets better. So he has a abdominal CT that also shows. Let's see if I can find it here. Maybe too early. He's got a filling defect right here into the right renal collecting system. And the best part, of course, is the lungs, where we've got airway-centered nodules, some bronchiectasis, some scar in the right upper lobe. So this is a guy with disseminated tuberculosis, with tuberculous epididymitis and tuberculitis, I guess papillitis would be the right name for it, involving the kidney. So got into the GU system as well. I've not seen a tuberculosis of the epididymis before. There's that filling defect right there on the kidney, which I thought was a great pickup.
Wow.
Speechless. And I believe he was from an area where TB is endemic, so not Wisconsin.
Minnesota, you mean, or
Seattle,
Chicago, maybe.
Was he from abroad?
Yeah, he was from. I believe he was from Mexico and was a agricultural worker here in the state.
Okay.
So presumably started in the lungs, got bloodborne, seeded the urinary tract, How it got to the epididymis, I don't know, but it did. So, usually, I mean, I was taught, and it's true, most epididymal things are benign. I mean, it's not tumor. This isn't a testicular tumor, but chronic GU infections, TB is up there, along with actinomycosis and other chronic bugs. All right, so that's all I got. It says the folks from Augusta are connected with the app now, so let's see if we can let them present.
Yeah. Hello, good evening.
Hi. So you just have to click the
Yeah,
screen, and we should be able to see your screen.
Yeah, can you see any screen?
Yes, we see your computer desktop.
Okay. So I will show a case of a 18-year-old boy. We did a cardiac MRI a few days ago, and I will show through some of the images and then show the few other images. So this is a 4-chamber view. And
so far, we just see your desktop. At least I just see your desktop.
Okay, just 1 second. Hold on. Okay. Can you see the screen now?
Yep.
Yeah. The 4-chamber view of a cine. And so we see what's the characteristic septal bounds. And there is a thickened pericardium here. So, and there is biatrial enlargement. And I will show you the same in the tagging sequence most of the time. Just a second. This one there. Okay, so I have the tagging sequence here. And so most of the time when we do tagging sequences, we look for any breakage in the tag. And in this case there is no break in the tags. So on the feature for constrictive pericarditis. And I will show you his chest X-ray now. So he has thickened calcific pericardium.
Mm-hmm.
So this was the case. He is being planned to be operated on in the next 1 to 2 weeks, and he has no other tuberculosis symptoms or any other symptoms. So it's like a de novo cases of idiopathic calcific constrictive pericarditis, presenting as kind of hematuria to a urologist, and workup started for chest X-ray and CT scan of the abdomen and pelvis, which showed very thick calcific pericardium.
Really dilated IVC too, I think. Down there.
Yeah.
Wow.
Yeah, so...
Can you go back to that MRI to play it in a cine type mode or slow motion cine, perhaps, if it's possible?
Yeah, sure.
If you can do that.
So this one, you can see the septal bounds and the interventricular interdependence, and so the characteristic septal bounds you can see here. So an echocardiogram, they had all the features, and we do see the calcium in the form of E2 dark intensity, low intensity. So they may do a cardiac cath next week before planning surgery. They are going to discuss it in the multidisciplinary conference on Monday and go from there. And there was no enhancement in the myocardium on any of the sequences that was performed. I can show you the delayed enhancement images. So this is the post-contrast delayed enhancement images. There is no enhancement of the myocardium. So most of the times when we are looking for constrictive pericarditis in MRI cases, we find it negative. So it's good to have a positive cardiac MRI to know really how exactly it's positive.
Yeah.
Okay.
And on the
And,
chest radiograph, there were some funny things up higher, which I presume were artifacts rather than something potentially interesting.
Yeah, they were outside the patient.
Clothing or something. Okay.
Yeah, yeah. So far, all the other medical workup, whatever ESR, CRP, those kind of initial workup which I looked in the chart have been negative. So if it was India, I think we would have thought of TB as the first cause. Here we have no idea what it is going to be, but I'll keep you posted if surgery is done here.
Great. Thank you.
Thank you very much.
All right, thank you. That was nice. All right.
Thank you.
Well, thanks, everybody.
All righty.
All right. 3 o'clock.
Have a good weekend. See you next week.
All right, bye.
Bye.